Diagnostic Excellence Summit. Thank you for joining us today. We are so glad that all of you could be with us. I'm especially happy to have Dr. Paul Rothman, Dean and CEO of Johns Hopkins Medicine, here with us today. For years, Dr. Rothman has been working to improve safety at Johns Hopkins and across healthcare. And of course, for the past several months, he, like all of us, has been laser focused on COVID-19. Dr. Rothman, thank you so much for being here.
Oh, thank you, David. Appreciate inviting me to start the summit. So this is an extraordinary time for all of us, especially in healthcare, where we are so focused on COVID-19. And it's really exciting to get together to have a group thinking about some of the challenges that we have moving forward. You know, Hopkins, like many other academic institutions, has been very involved, and I would argue leading the way in this pandemic, from our research to our operations to the great folks in public health and epidemiology and engineering who have our website up, and also on the policy front. It's really great that David and the Armstrong Institute has organized a summit today about the diagnostic strategies with the pandemic. It's something that we think about a lot. And I'm really excited to hear about some of the issues that our speakers are going to discuss today, because it's bringing together folks from our school of medicine, our school of public health, along with others from the university and from around the country. It is really one of the most important issues we're dealing with as we fight through the COVID-19 pandemic. Before I get started, I want to introduce David Newman-Toker, who's the host today. He's the director of the Center for Diagnostic Excellence here at Johns Hopkins. He's a professor of neurology. Most of his work had been focused on stroke diagnosis, specifically in the emergency room. Has developed really very interesting point of care technologies to help us diagnose vestibular strokes, and has been a leader in our Center for Diagnostic Excellence. And David, thank you for leading the summit today and for refocusing your work to really what is the most important topic that the world is facing, which is the COVID-19 pandemic. So look forward to hearing the speakers and learning more. So David, thank you again.
Thank you so much, Dean Rothman. We are really grateful for your being here, and thank you for your leadership. I'm just going to turn to a few introductory slides and before we get started with the first panel. Today's conference is entitled The Diagnostic Strategy for the COVID-19 Pandemic, Bench to Bedside to Blueprint for Policymakers. This conference is hosted by the Armstrong Institute Center for Diagnostic Excellence. Our mission is to innovate to achieve diagnostic excellence and accountability for Johns Hopkins, the region in the world, by eliminating preventable harms from diagnostic error, optimizing patient outcomes and experience in diagnosis, and reducing waste in diagnostic assessment. And we envision a world where diagnoses are accurate, timely, and effectively communicated to patients, avoiding both diagnostic error and overdiagnosis. We see a future in which diagnostic processes are patient-centered, evidence-based, prompt, efficient, safe, and equitable. And I hope that we can start to move in that direction for COVID today with our summit. Again, I'd like to thank our leadership, Dean Paul Rothman, and the director of the Armstrong Institute for Patient Safety and Quality, Alan Kachalia, as well as Michael Armstrong on the right-hand side of your screen, without whose generosity the center would not exist. Your learning objectives today: number one, to describe strengths and weaknesses of SARS-CoV-2 diagnostic tests, including RT-PCR and antibody tests. Number two, to discuss clinical diagnostic issues in assessing COVID-19 and non-COVID diseases during the pandemic. And number three, to list public health and public policy approaches to optimize diagnostic strategy during the COVID crisis. The virtual conference schedule is broken up as follows. After this brief introduction, I will hand over to Yuka Manabe to lead a panel talking about the state-of-the-art science of SARS-CoV-2 diagnostics. It's an impressive panel of incredibly knowledgeable experts on diagnostic testing. We'll then have a session from 12 to 1 focused on patient and provider perspectives on diagnosis in the COVID era. It'll be led by Susan Peterson, Kathy McDonald, and featuring a presentation by one of our graduate students, Mani Kaita, as well as 5 breakout sessions, among which you'll have the opportunity to shift and share, which will be explained later on by Dr. McDonald. The final session will be led by Josh Sharfstein, a panel with Mark McClellan, Lucy Wilson, and Ashish Jha, our public health and diagnosis during the COVID-19 pandemic. And then we'll close with some summary remarks at the end. I hope that you can stay with us for the duration of the conference, and we're very excited. The conference leaders, this is an incredible group of colleagues of mine that have put together today's conference program, and we're very grateful that they've been able to do that. This has been a team effort. We have a number of guest speakers, invited panelists from around the nation who are devoted to and committed to improving this problem, and many of them, their names will be incredibly familiar to you today. And we have a host of JHU speakers in addition to that, that we're looking forward to hearing from in their expertise during the breakout sessions. So with that, I will turn the conference over to our moderator for the first panel, Yuka. Take it away.
So good morning. It's really a pleasure to be here at the summit and to be hosting this first panel on state of the art for SARS-CoV-2 diagnostics. I have a great panel that is going to talk about everything from molecular through serological to perhaps diagnostics that have not yet been imagined. I wanted to start off just to orient everybody to a figure that we made that is really just for illustrative purposes. I hope you can see that. It's important to see that if you think about the course of illness, first people go through an asymptomatic phase, but even during this phase, it's possible to diagnose people using molecular diagnostics, RT-PCR. And then the symptoms start up and we can still see RT-PCR positivity, and that starts to decline such that by a median of 2 weeks, most people will have become negative, though there are people who can persist with RT-PCR positivity, sometimes depending on immunocompetency status and also due to other things, other host factors that maybe we don't understand yet. Then there's a time where antibody responses start to come up. This is varied depending on the literature and depending on the isotype of the antibody. If it's an IgM, it might come up maybe around a median of 5 days, IgA a median of about 8 days, and then IgG somewhere between 10 and 12 days. So you can see that depending on when you see a person to make a diagnosis after the onset of symptoms, you may want to use different diagnostics to try to make the SARS-CoV or COVID-19 diagnosis. Interestingly, there's a first viral response phase and then a host inflammatory phase. And it's really this host inflammatory phase that perhaps contributes to hospitalization, acute respiratory distress syndrome, such that based on a Lancet article, maybe the mean time of death is sometime around 19 days. It has been seen in some articles that the total antibody does correlate with severity. Sometimes IgG can persist, and somewhere between 1% and 5% of people may never develop an antibody response. And whether or not you develop an antibody response, it may or may not then correlate with neutralizing immunity, meaning that you would then potentially be protected in the future. So we're going to sort of touch on some of these issues. To begin with, I would like to first have my panelists introduce themselves, starting with Heba and then going to Galit and then to Todd. So Heba, I'm going to mute myself. Please introduce yourself.
Hi, good morning. Thank you so much for organizing this wonderful meeting. My name is Heba. I am the director of the Molecular Virology Lab at Johns Hopkins Hospital, and I'm currently responsible for the molecular diagnosis of SARS-CoV-2. So I came from different places actually. So I had medical training in Egypt. I had microbiology training in the University of Kansas and at St. Jude Children's Research Hospital, and then I had medical microbiology training at the University of Rochester Medical Center in New York. And I joined Hopkins last year, just in time for the outbreak. And I will be happy to discuss our diagnostics strategy today. And I will hand it to Galit to introduce herself.
Hi there. So my name is Galit Alter. I'm a professor of immunology and medicine at the Harvard Medical School, at the Reagan Institute, and the Massachusetts General Hospital. My laboratory focuses on the development of antibody-based diagnostics, both for diagnosing infections initially, as well as in understanding biomarkers associated with differences in disease outcomes. And I'll be talking about our efforts in the serological space to stand up assays that can help to diagnose individuals.
Todd?
Yes, thank you, Yuka. So Todd Merchak, I'm a program manager at the National Institute of Biomedical Imaging and Bioengineering within the National Institutes of Health. My primary responsibilities involve management of small business programs in the engineering space and imaging space. But with regard to this conversation, I'm also serving as a co-lead on our Point of Care Technologies Research Network program, which is a networked resource of 5 centers supporting point of care technology developers in translating, validating, and commercializing innovative point-of-care diagnostic approaches. Thank you.
Great, thanks. So as you heard, and maybe as you all know, one of the first things that happened after COVID-19, at least in the United States, was an attempt to bring up RT-PCR technologies. And though there was one that was prepared early on, that one proved to be not enough, essentially, not enough to cover all of the diagnostic need. So Heba, maybe you could start by telling us a little bit about what happened here at Johns Hopkins and what you had to do in order to stand up a molecular diagnostic in our hospital system.
Sure. Once the outbreak happened in early January, or I should say late December, the situation in the US at that time was not very clear yet. And it was not really until the beginning of February when the first CDC assay was available, and it had its emergency use authorization. However, at that time, the testing was really restricted to the CDC or certain public health labs, or some of those labs selected by the CDC. At that time, we actually tried to contact the CDC and to contact the responsible distributing groups to try to get the CDC diagnostic kit, but we were not eligible at that time. And when there is a CDC EUA assay, we can't actually, as a lab, develop any diagnostic assay unless we get an authorization. But then the outbreak started to quickly evolve, and there was a critical need for increasing the capacity for diagnostics. And at that time, the FDA finally gave the permission to the high complexity labs to be able to develop their own assays and submit their own emergency use authorization for the assays that they decide to develop in the lab. So we right away started to work and validate an assay to offer testing at Hopkins. Our very first assay was live on March 11th. So it took us a very few days to develop our very first assay. So I will try to share my screen. Just 1 second. Just to show you a few slides. So practically speaking, all our assays are based on a PCR. It's PCR based, And we target different genes in the SARS-CoV-2 genome. And as Yuka mentioned, probably this detection of the virus is like an early, it starts earlier than other serology markers and so on during the course of the disease. And if you detect really the genome of SARS-CoV-2, this is a conclusive diagnosis. So this is for now, actually, or until now, it is the gold standard for diagnosing an active infection, or I should say a current infection with SARS-CoV-2. So the different molecular methods that are available right now, there are a lot of them that target different genes that include the polymerase or the S gene or the E gene. And in the lab here, so our very first assay that we went live with was this lab developed test. And right after this assay development, we started then to add additional assays. Now we have about 8 different platforms to run diagnostics for SARS-CoV-2. And the reason for this is that since we started offering testing in-house, we were faced with problems that started with supply chain issues for PCR reagents. And then we were faced with issues with extraction reagents, and then additional issues that are related to viral transport media and swabs and so on. So we decided that the best strategy to maintain testing capacity is to try to validate different platforms that will allow us to maintain this redundancy in testing. So we will be able to try to maintain a continuous or at least reliable supply chain if any issues happens with a specific company. Supply-wise. Also, we wanted to add platforms that can allow a quicker turnaround time, which include here, for example, this Cepheid Expert Assay that can offer the result.
Heba,
Sure.
sorry to interrupt. I think it's not advancing. Are you advancing?
So can you see my table?
Nope, we are just seeing the coronavirus.
Oh, I'm sorry.
But that's okay. It's a very pretty picture. You should continue. You're doing explaining.
Sorry, I think I'm in the.
Hey, Heba, if you click on full screen, the bottom right, that it looks like a project, or if you go to slideshow and then click start.
And then I would try to make it bigger. Perfect.
There we go.
All right, sorry.
It's okay.
So I think I was also on the wrong PowerPoint. So other assays that we added also offer a quicker turnaround time that include the Gen Expert. But however, we are still are facing issues with the supply chain that really limit offering this for larger group of providers. So we are limiting it, for example, to stat assays from the ED. So this is where we are right now, and I will call this like phase 1 SARS-CoV-2 molecular testing. And as of yesterday, we just crossed our 20,000 tests, and we passed 3,000 positive specimens diagnosed in the lab. So I described this as phase 1 because now we are thinking about phase 2. And what it brings from, or what we need to do in order to assist with the next step, which is opening Hopkins, including research labs and outpatient clinics and so on. And what do we need to do in the lab to increase the capacity of testing further in order to allow for screening whenever needed? So I think I will stop here and take questions and open it for discussion.
That's great, Heba. So just to say, I think you're getting a sense of what a heroic effort it was really in order to get diagnostic testing going here at Hopkins. It required being in front of the field to get reagents, and I really congratulate Heba for making it testing available for the whole Hopkins community, and also for leading her for her leadership within the state. So next, Galit's going to give us a sense of what it's taken to think about serologic diagnostics, and also what the Reagan Institute has been doing to stand up their own assays.
Sure, thanks so much, Yuka. So I'm going to just share my screen as well, because I'm going to talk about some of the chaos that has emerged in the serodiagnostic space. So in late January, damage control was underway and the world's community refocused on the development of RNA tests. And that was clearly outlined just before. They were essential for supporting those who were seeking care. They were coming to the hospitals with symptoms of the disease. However, it wasn't long after the symptomatic individual started testing negative routinely on RNA tests that the need for serological testing became clear. While RNA shedding is transient and sometimes stochastic, antibodies usually do not falter. And just a week after infection, as Yuka described, we can detect antibodies in nearly all individuals that are infected. Now, the government placed the responsibility on the scientific community to generate antibody tests, to which the community responded. But what happened, instead of generating high-quality assays, is that the market was flooded with ELISAs, thousands of different ELISAs, many of which did not work. And this led to the White House having to convene a serologic assay think tank and an advisory committee to raise the bar and demand the highest quality from antibody-based diagnostics. Now, the reason for a need for quality testing and assurance from the FDA was clear after thousands, if not hundreds of thousands of tests ordered in England failed to detect SARS-2 infection in people who were clearly RNA positive in a few days out from initial infection. And so what ended up happening is many groups, including groups at MGH, as well as this group at Stanford, shown here on the right, began to collect every single serological assay that they could get their hands on from across the US, as well as across the entire globe. And this led to multiple evaluation efforts to try to understand exactly which assays gave effective responses, high quality responses, and the responses that would be required to receive an EUA from the FDA. So what happened is that what we actually see on the market now are three different kinds of tests. And I just want to go through these very quickly just to give you all an idea of the types of serological tests that are out there and which assays are fit for purpose for different types of utilities in the clinical space. So the first one is a rapid diagnostic test, otherwise known as an RDT. It is a qualitative test. It is small, it's portable, it tests one individual at a time, and it just tells you if somebody is positive or negative. And the neat thing about this particular assay is that it gives you a response literally within minutes. The second type of test is an enzyme-linked immunosorbent assay that provides qualitative, also could provide quantitative data, although most commercial kits are currently only giving a yes or no answer. And the neat thing about this assay is we can run up to 90 different individuals on a single plate, even up to 384 individuals. So it really allows us to capture information quite rapidly. And this type of data comes out in just a couple hours. And then finally, the third class of tests that Yuka mentioned are the neutralization assays that may tell us about the flavor of protective antibodies that may be most important to limiting disease. These tests are both quantitative as well as qualitative. These measure the ability of antibodies to block viral infection. These are lab-based tests, and unfortunately, these types of tests take days to measure. And so what ended up happening was that these tests started flooding the market. There was an incredible effort to try to really understand which tests would work and which ones would not. And in the end, what the Reagan Institute with Mass General Hospital did is to decide to basically build our own assay due to supply chain issues, as well as cost, as well as scale up. And so what the Reagan Institute did in partnership with Massachusetts General Hospital is essentially build our own assay. So I'm just going to zip through to that slide. And so what we ended up doing is identifying components of the virus that were easy to scale, that were easy to produce, and that were incredibly stable. This is a tiny little region of the spike antigen involved in viral infection, so the antigen that is critical for driving attachment and then ultimate infection by the virus on the ACE2 receptor. And we use this tiny little protein to essentially coat plates, capture antibodies, and develop ELISA-based assays. And what you can see over here is the quality of the data here in the RNA positives in the red and the RNA negatives in the blue. And what we can see here is that we get this incredibly beautiful resolution across different isotypes using the full protein as well as using the RBD itself. So this gave us really a platform to develop an incredibly high throughput assay that has now been deployed across multiple different sites across the US as well as across the world. We did an extensive amount of optimization to make sure the assay was really great. And what really came out of this is this ability to resolve individuals who are positive from those that are not, both in the pre-pandemic era as well as in the current pandemic. And I think that the most important revelation here was that we could really quantify, not just say yes or no. We could quantify if individuals were IgG, IgA, or IgM positive. And this was discrete and very different than what we saw in the control individuals. But what I want you all to note, and I think this is really important, is the degree of diversity of responses we're seeing at the population level. So there are some individuals who have very high responses, other individuals that have very low responses. And so the question really is are these tests only telling us about exposure, or could they be telling us about immunity? And the point that I think is important to just bring up on this particular panel is the fact that while serodiagnostics give us this window of opportunity to identify who is exposed and who is not, these tests do not necessarily tell us who is immune, and that seroepidemiological studies partnered with using RNA and antibody tests is likely to be essential to ultimately identify what the thresholds of immunity really are.
Thanks so much, Galit, for that overview. So with that, I'm going to move on to Todd, who's going to tell you a little bit about what the National Institutes of Health, and particularly NIBIB, is thinking about how to approach COVID diagnostics. Todd.
Yes, thank you very much, Yuka. So I'm actually sharing with you today what's hot off the presses as of a few moments ago, where the NIH recently announced their new initiative aimed at accelerating the innovation and development pipeline of diagnostic tests for COVID-19. This is with a $1.5 billion investment from the recent federal stimulus funding to stand up what we're calling Rapid Acceleration of Diagnostics Initiative, or RADx, aimed at sort of a twofold approach. One is trying to stimulate sort of new and innovative technologies that can be used more at the point of care for detection of SARS-CoV-2, as well as looking to optimize and scale existing or advanced technologies that are already on the market. The goal of the recent stimulus funding and the goal of this initiative is really to get the American testing system to a scale that we need to be to allow for the ease of lockdowns and allow folks to go back to work and back to school, ideally by the fall at the latest. As a component of this overall effort, up to $500 million is being dedicated to the Point of Care Technologies Research Network that I described briefly in my opening remarks. And again, this is a network structure that allows for sort of the rapid intake of proposals related to point of care diagnostics in this space, very rapid screening, ideally with turnaround time within a week, and selection of projects to move on to sort of a deep dive or Shark Tank phase where each proposal will spend a few days up to a week with the project management team led by business executives and medical device industry executives to really understand what the risks are with bringing the technologies forward and what milestones, timelines, and budgets would be required to move this to market rapidly. For folks to make it through that process with a detailed work plan identified, they will be seed funded with some initial capital to do clinical validation work towards FDA clearance or EUA, and then for projects that make it through those milestones, additional capital that will be deployed within the next several weeks with a goal of getting promising tests to market. This will certainly involve multiple partnerships, not just the NIH, but bringing in our colleagues at the FDA and BARDA as well for their expertise, from early stage research all the way through manufacturing, distribution, and clinical practice. This will also involve the private sector as well, especially when we're talking about sort of the supply chain and scale up the manufacturing. and distribution approaches. So we also have part across the diagnostic space as well as more broadly the manufacturing community to ensure that we have all the necessary components in place to achieve our aggressive goals of getting diagnostics scaled up by the fall. I can announce that this initiative is live now. So for more information, you can visit poctrn.org, POCTRN.org, and there'll be a link at the top for the RADx program, which will provide additional details on what's being solicited and review criteria and more details on the program. At this point, our goal is to spread the word as broad as we can, so we can certainly use everyone's help. Make sure we're reaching all the innovators out there that have novel ideas, early stage as well as advanced ideas for testing, direct testing of SARS-CoV-2. And I appreciate your time and attention today. Thank you, Yuko.
Well, you've heard it here first at the summit, $1.5 billion, which I have to say is truly fantastic, and I think can really move the needle of trying to get some good diagnostics out there for the diagnosis of COVID-19. So I'm now going to open it up to the audience. It's my understanding that Sharon has a question, which I cannot see in the chat. So I think that Vanessa's going to unmute you so you can ask your question live. Sharon, are you able to unmute? All right, well, while Sharon's trying to do that, I was just going to have maybe everyone on the panel can turn on their video and we can maybe talk a little bit about why you think SARS-CoV-2 is such a challenging virus, or maybe you don't think it's challenging. So I would love to hear from all of you about whether or not what you think the specific issues are around SARS-CoV-2 compared to other organisms that you've worked with.
So maybe I can go first. Oh, Heba, do you want to go first? Go ahead.
Oh, go ahead.
I was going to say it's time. There's nothing really challenging about setting up an ELISA or an RDT. That is not challenging. The technology is there. It's been around for decades. I think the real critical issue right now is time, and it's reagents and scalability. So I think that it's developing systems to make sure that we are not resource limited when it comes to both the reagents as well as the funding that is required to push this forward. And so we're very thankful that Todd made his announcement today. But I think that what we really need is we would need an extra couple hours in every day and a couple extra days in a week, and then we would get to where we need to be. But I think that the point is that by working together as a community, and not as individual entities, I think that's how we're making the biggest dent on this particular crisis.
Right.
I think that's right. I think we've come together as a community. That's great. Heba, go ahead, and then Sharon, you can ask your question. Go ahead.
I think the situation with SARS-CoV-2 here in the lab is unique, and I have never experienced anything like it. So we were faced with issues of bringing sensitive diagnostic in a very short time. Then we were faced with supply chain. Then we were faced with capacity. And when we were almost confident about the analytical performance of our assay, we were faced with questions about the clinical sensitivity of the assay, which we didn't have much information about. There is a lot of uncertainties around all the diagnostics right now when it relates to SARS-CoV-2 and what they mean. What does it mean if there is a patient who was negative by PCR that is now positive with a high CT value? What does this mean? What does it mean when you have shedding by PCR for more than 3 weeks? Does this mean that this is infectious virus or not? Should we keep isolating the patient or not? So a lot of uncertainties and questions still around this virus, and we need to understand more. I'll give it to you, Sharon. You can ask your question.
Go ahead, Sharon. Sharon, we can't hear you, but I see you're unmuted, so I'm not sure. Okay, well, while we're trying to wait for her, it looks like there's another question here. What are the key questions that Todd would have for Galit? Are you scaling up her technology? So we're already having some matchmaking going on here at the summit. Todd, what would you tell Galit in order for her to quickly be able to access your opportunity?
Sure. So, obviously connecting with our point of care technologies research network is sort of the first step. Again, we've sort of assembled, and I skipped over a lot of the details, but we've assembled sort of a fairly large network of individuals to serve as reviewers and project managers for this sort of deep experience in the medical device industry, as well as technical and clinical folks who have deep expertise in those domains. And so we feel confident that bringing that network of human resources together with innovators who have novel ideas at any stage of development, we can sort of help again think through what are the remaining barriers to get to market and help provide you with the resources you need to get there, whether it's funding, whether it's clinical validation work, whether it's partnering with manufacturers and other technology developers for scale-up device design, quality systems, all those things we're bringing to bear on this problem. So we don't have enough time in this session to get into all those details, but suffice to say, we're willing to bring the resources necessary to get these tests to the market.
So that's great. So I want to follow up that, Galit, with, do you have an idea for how to make a neutralization assay that won't take days that we might be able to use? Or do you envision that we are going to use neutralization assays to figure out which isotypes are the most important in neutralization and then use that as a surrogate? What are you imagining is going to happen?
So there's efforts on both fronts. So I think that the important, development on the neutralization assay side is that there are efforts to identify multiple different cell types in which the virus might replicate more effectively or more aggressively, so we can get a readout faster than having to wait, 2 or 3 days to actually see viral luminescence. There's also much more sensitive detection approaches, and so all of that is really in play, and that is happening, really, I would say at light speed. Given the urgency in this epidemic. And I think we're going to see more of that kind of technology popping up, especially with Todd's potential, this effort that, they're spearheading to help to really support the engineers that are looking for these more sensitive readouts and markers for these new cell types. On the other side, I think that the other point is that we may find that there are other biomarkers that are associated with protection, and it may not be neutralization. And I think that what is happening now is this aggressive push on the pathogenesis side to study these samples that are coming out from these large seroepidemiological cohorts to identify the biomarkers and potential additional antibody mechanisms or surrogates that are tracking with neutralization that may be way faster and way easier to measure. So I think that it's this parallel effort that has to be supported because we don't really know if neutralization is going to be the correlate of protection for this particular disease, although we do assume it is based on data from other respiratory pathogens. So the answer to your question is we're working on both.
Yeah, so maybe also to follow up then, I think I would like to ask the panel to discuss how they think SARS-CoV-2 really revealed issues around pandemic preparedness from a diagnostic standpoint. I've been working in diagnostics for a long time, and it's never been as front and center as it has been with SARS-CoV-2. Often people take it for granted that there will be a diagnostic for their clinical need. And in this case, it's not just whether or not you have a test, but it's also whether or not you have all the pieces necessary. I think all of you have brought up how there are supply chain issues, nasal swabs that we can't get enough of, not enough viral transport media, not enough PPE to get the test, and so forth. So I see some innovation possibilities around even what the sample type will be in order for us to do the test. But what do you think about SARS-CoV-2 and how it relates to diagnostic preparedness?
I think I will start. I would say that we were quite delayed from the beginning. We were delayed in the widespread nationwide diagnostics because of regulations. And if we started hitting the diagnostic development earlier and offering it in a wider scale really early, that would have made a huge difference. And we could maybe have like realized our needs a little bit earlier, but also we could have controlled the spread of the infection a little bit better, which might not then, maybe the supply chain issues then would have been also better. But I will say we had like a few weeks of a delay. So this is the biggest issue that we had in the beginning. But as also you mentioned, I think now we realize what it means when we need to have mass testing, and we now know what it means when you need to offer a PCR assay or a serology assay for every single person in the US. We are not prepared for this, and I don't know if this is like if we can actually be prepared for something like this. But with my experience, I feel like everybody has been working really hard, and we have been at least meeting a reasonable, I would say, a reasonable achievement of this goal. And I was very impressed of like how much assistance and how much cooperation between different teams. And how much like creative some groups have been trying to, for example, do a 3D printing of swabs and 3D printing of vessels for extraction. So I will stop and give a chance for Galit and to talk.
So if I can go first, Todd, because I want to, if it's okay. So I just wanted to just say that I think that there's a specific problem with the serology, and that there was an either or at the beginning of the response to the pandemic. You know, it was, let's prioritize RNA and we'll think about antibodies later, and that cannot happen. And I think what is clear from this epidemic is that, you know, RNA gives us one window of opportunity to understand who's infected, and antibodies provide another one, and it cannot be an either or. I think, you know, proposals to only do RNA testing at a population level, you know, may lead to a lot of false negatives. That is not beneficial for guiding policy. It's not helpful in guiding who's going to be protected when they come back. And we've seen these manuscripts popping up and then being retracted. We're seeing, you know, all kinds of op-ed pieces across the news media. And I think it's incredibly important to understand that these two technologies linked together is what helps us understand who's infected and who is exposed and who might still be infectious. And so I think that is really something from a pandemic preparedness standpoint, where we have to put our eggs into both baskets and make sure that they're happening together in parallel, so that we can really get the most of our diagnostics. And then I think to Todd, I think that, you know, what I was hoping that you can address as well, if I can, from a panelist to a panelist, ask the question as you answer the question, is, you know, there's obviously a lot of interest in, you know, driving innovation. And we need really interesting kind of neat little devices. But there are also meat and potato assays, right, that are really the workhorses. And it's not clear to me how much is going towards these, you know, very basic PCR tests and ELISA tests. It may not be, you know, a 22nd century assay, but they are assays that really, you know, can be scaled and can really be effective. And so I guess my question to you is, from a pandemic preparedness standpoint, how much of the effort is placed into these standard workhorse assays versus what is truly going to be innovative?
Yeah, thank you. That's an excellent question. So I'll just start, you know, from the federal level. When we talk about preparedness, I think the unique thing with this situation that everybody recognizes is that the scale of it is much greater than anything we've ever seen before, had to dealt with before. You know, needing tests in every corner of the country at various clinics, and you know, I think from the start, you know, obviously we would have been in a much better situation had we had, you know, diagnostics in place so we could start tracking and doing the surveillance, because that'll allow us really to help with this distribution problem of where to send resources and when and how much. This has been a massive challenge. I think we've learned a lot over the last several weeks in terms of existing testing infrastructure and what's currently working and where the gaps are. So we have a pretty strong understanding of where the support needs. I think, you know, the unique point that we're at right now is that because most of the economy has kind of stopped, everybody's turned around and focused on this issue. So we have the full resources and capabilities of all the private sector and public sector in the United States sort of looking at this. And so we're currently organizing all those folks. Really, to your point, this $1.5 billion, as it was announced today, is going to be a multi-pronged approach. So there's some of that funding that will be going towards scaling up and optimizing the current existing infrastructure that's there. Working with those manufacturers that have these PCR-based tests and other assays to figure out how to increase throughput in the near term. So we have testing, and that's currently being done, and that will be rolled out in the near term. The real point of the innovative diagnostics is to get because if we're going to really truly do massive screening before we get everyone back to work in the fall, we need much better screening tools in terms of sensitivity and specificity for detecting the virus itself. We won't be able to have Americans won't be able to have the confidence to leave their house, go to events, public spaces without a good sense of knowing who's carrying the virus. And then on top of that, and this this is another ancillary piece to this that we're working on, is really the digital health platform is kind of what's going to tie all this together, because the testing itself is great, but that needs to be tied together in a broader EHR framework, so we can do survey, do contact tracing in a much more efficient manner. And so we are working with the private sector on a broad smartphone app that will be in place to convey the data and use that for really hoping to contain this virus.
So that's great. So I think we've heard a little bit about how to have a more global approach with meat and potato assays, as we've heard from Galit, but then also to think about where innovation can be the most effective in moving the needle of public health. So there's a couple of questions that have come up on the chat. I think that you piqued a lot of interest, Heba, with your "became positive again" comment, which I think has made some of our audience wonder what that means. And the second one was, I think, towards Galit. Any estimates on the sensitivity of serological studies in comparison to PCR? That's a tough question, but I think you're going to have to reframe that the way you want to answer it. So maybe I'll start with Heba on "became positive again."
I think we have to become positive in this situation. So as I mentioned, we are trying now to move.
Oh, no, Heba, I think she meant is when you said that there was a person who was PCR negative who then became positive. And then, yes, go ahead.
I'm sorry. So yeah, we had some occasions when I was asked or consulted about specific patients where they were positives, and then on the follow-ups they were negatives, and then they started to see positivity with like high CT values, which means really very low viral loads. And the question was like, what does this mean? I think from my perspective, it looks like, and based on the literature, the viral detection by PCR lasts for quite a long time. It might be actually about like 3 weeks. We don't really now know why this low detection, why do we detect this low viral load after a negative, but my interpretation from the analytical standpoint is that if you have a specimen that has very low viral load and you repeat it twice, you might have it a negative one time and a positive in the other time, just because the load is below the lower limit of detection of the assay, which is totally acceptable from a molecular point of view. So it might have been negative just because it was very low shedding, and then we picked it the next time with the next specimen. The cell culture studies are currently going to answer whether those CT values means infectious virus or not, and it looks like our preliminary results indicate that they don't grow on cell culture, but this to be confirmed.
Thanks. So just to clarify for those of you in the audience that don't spend a lot of time in the lab, CT stands for cycle threshold, and it's a PCR term to show how long it took to amplify the target DNA or RNA in the PCR reaction. And so the important part of that is that high cycle thresholds mean there's not that much DNA or RNA to be detected in a PCR reaction. And so I think that that is a quantitative part of what is actually reported as a qualitative assay. So what do I mean? You get an answer from Heba's lab that says yes, positive, or no. So detected or not detected. And there is a level above which we would say it was not detected. And that is determined in a lab developed test by the lab or in a commercial test by the manufacturer. And I think it's important to understand that. So it gets reported as a qualitative, but you can actually go back and look at the assay and quantitatively see what the cycle threshold was. That is not reported to you though as a user. So just to make that clear. And then Galit, you're up now on sensitivity.
Sure. So I think one of the best cheat sheets right now in the world is on the Hopkins website. And so I think I commend, Hopkins team for putting that up. And so there's this incredible list of assays that are out there from commercial vendors as well as from academic groups that show sensitivity and specificity levels. And I think that what is clear is that the level of the assays are clearly, outstanding, where there are multiple assays that are showing over 90% sensitivity and specificity. And so I think what that tells us is these antibody tests are extremely good. Now, what I think is important to note is what type of samples they're using to assess their sensitivity and specificity. So most of these individuals, most of these groups are using convalescents that are weeks out from infection. And so they're getting these beautiful discriminations, kind of like what I showed you guys, that's like, 95% and above sensitivity and specificity on those assays. And so they're absolutely incredible at defining those who have experienced SARS-CoV-2 and those who have never seen it before. The issue is that early on in the disease course, as Yuka had shown you with the trajectory of the antibodies, is there's about a 5 to 7 day window where sensitivity and specificity is really not that great. I mean, I think specificity is there. There's no question the assays are working. The sensitivity issue is that at about day 5, we're only about a 50% sensitivity in some of these assays. But there are new higher sensitivity assays or, single molecule quantification approaches, Todd, which I'm sure you've seen from some of the developers that are out there, that are picking up infections even at day 3 by looking at IgMs and IgAs. So I think that we're getting closer to developing tools that will pick up the response earlier on. What my feeling is that from a seroepidemiological standpoint, if we understand the sensitivity issues with early infectious disease, we can bridge the gap and add RNA testing with antibodies to really get a feel for what's going on at a population level. Within our clinics, we do this anyhow, where we're coupling RNA with antibody anyhow as we progress in this epidemic. And so I think that we have a good feeling based on this knowledge of what sensitivity and specificity looks like to be able to use these tools in a complementary way so that we can really understand what's going on with the disease.
Okay, so I want Tom to know that I'm going to leave his question to the next panel, which is what would you most like to see legislators and policymakers do to remove barriers? I think that's coming up this afternoon. I think I'm going to wrap up here so that we can stay on time and David remains my friend. So first, just to say, we have very good RT-PCR tools. We also have very good serological assays that are currently being used primarily on blood. I would say that these are going to remain the workhorses as we start to potentially reopen up our country and reset. I think they're going to remain the tests that we use. I think there's great optimism that there might be ways to tweak those assays, have innovation, decrease the level, increase the sensitivity of the assays, and perhaps think differently about how we merge all of that information to understand what's happening with the pandemic here in the United States and worldwide. Secondly, I think we learned something about pandemic preparedness, that having good assays alone is not going to help in isolation, that we need to think about supply chain, we need to think about what's necessary to do those assays, and about the people who are taking the specimens, and maybe to think more creatively about times where self-collected compared to clinician-collected might be a way to go. There are clear gaps in our research knowledge. What are the important isotypes? When do they come up? In whom? Does the severity of the illness matter in terms of what your immune response will be? We know all of these are likely true, but the granularity is still not there, and I think there are clear research gaps. And finally, I always like to say, I like to rib all of my engineering friends. In this case, it'll be Todd, since he's the one on the panel. I'm always amazed at how bioengineers are so much more optimistic than doctors. Doctors tend to be pessimistic about everything. And maybe we will take a page out of the bioengineering book, realize that it takes a village for us to move forward and remain optimistic. And I leave you with my favorite African aphorism. I lived in East Africa for 5 years, and it was always, if you want to go fast, go alone. And if you want to go far, go together. So hopefully this is the beginning of more collaboration. It's like drinking out of a fire hose. I've never had as many emails as I've had during the last 8 weeks. It feels to me like the last 2 months might have been already a lifetime. But we remain enthusiastic, remain hardworking, and we will still continue to do what we do in order to make sure that we do our part against COVID-19. So with that, David, I shall pass over to you and thank all of my panelists for participating. I really appreciate it. Your viewpoints were invaluable. So with that, David, off to you.
Super, an amazing panel, Yuka. Thank you so much. Heba, Galit, and Todd. This was just an amazing opportunity for us to hear on the inside all the details of where diagnostic testing is at around the COVID-2 virus. I'm going to hand off now to Susie Peterson and Kathy McDonald to move us from the bench to the bedside, and they're going to introduce the next session. So take it away. Thank you.
Thank you, David, and thank you, Dr. Manabi and panelists for that wonderful session. We're going to now move to the patient and provider perspectives in diagnosis in the COVID era. In a few minutes, we are going to be breaking into shift and share sessions, which Kathy McDonald will describe in a few minutes. Those sessions include point of care ultrasound, telehealth diagnosis, responding to patient experiences and concerns in the midst of the pandemic, preparing for the second wave, and clinical data repurposed for diagnosis and tracking in the outbreak. But before we move to the shift and share sessions, we want to return to the core of what we do, which is the patient. As a frontline clinician in the COVID era, it is clear that there is a sense of fear often for patients who are accessing care at this time. And it's amplified by a lot of factors, including sort of spacesuit-like PPE from the providers, these atypical care environments like tents that together are reminiscent of something out of the movie E.T. And it's further exacerbated by things like visitor restrictions that prevent patients from having support from family and friends at difficult times like this. So this morning we have Mani Kaito with us, who is going to share a recent experience that she had accessing care during this challenging time. Mani?
Hi, everyone. Can you all hear me?
Yes.
It's a real pleasure to be on this panel and to participate. I'm a PhD student in health policy and management at the School of Public Health. But today I am presenting my perspective as a patient. I think that my dual identities as patient and researcher are very interesting for informing how one can navigate the healthcare system, and kind of it presented a little bit of this out-of-body experience. The patient was in the room, but the researcher was out in the atmosphere just observing and trying to take in data. But in the next just handful of minutes, I'd like to share a little bit about my experience, and my intention for these next few minutes is that my experience and my thoughts would inform your own self-reflection and inform the way in which you conduct your own research and develop your research questions. Because after all, science is more or less the study of how the world works. And as researchers, we like to remove ourselves from the experiments, but in the case of social science, we are inevitably part of the data as well. So I'll begin with the end, which is that I went to the ED in April. So right in the middle of all the coronavirus fear and media going on. And it was a pretty scary period for me. What I realized is that the heightened awareness during this period really, in my opinion, increased barriers to diagnosis. And when I think about diagnosis, I really see it as a pathway. And it begins before you even make it to the ED or to the healthcare system. So diagnosis really begins with the patient's own acknowledgement of his or her own symptoms. So I had been feeling shortness of breath and chest pain, and sadly, I feel as though it took me too long to get to the ED. And the reason why is because I was afraid. And I told myself, well, perhaps my symptoms are not that bad, because if I go to the ED, maybe I'll catch coronavirus, or what if I already have coronavirus? Am I even going to be able to take care of myself? So I already had that barrier that to a certain degree prevented me from engaging with the healthcare system. Then I put my researcher and public health professional hat on and really decided that the wise thing to do is to engage with the healthcare system. Better be safe than sorry. And then once I was at the ED and I actually began the formal engagement with the healthcare system, my interaction with the providers were a bit tense. You know, everyone is definitely worried. Could she be a coronavirus patient? Maybe not. I only had one of the trigger symptoms, so they weren't quite sure what to do with me. And I find that also our communication was a little bit tense. There was some questioning of whether I was actually experiencing these symptoms, being that I'm young and I don't look sick. But in that moment, you know, it's really important as the patient to just try and be clear with what it is that you're going through. And then once I left the ED, I received an unspecified chest pain diagnosis, which, suffice to say, is not incredibly helpful. I didn't completely understand my diagnosis. So that's continuing along the diagnostic pathway. Does the patient even understand what's going on? Very deep within the paperwork, I saw some information about perhaps another viral infection, viral pericarditis, and that actually was pretty informative. And I was able to take some anti-inflammatory medication, make a few dietary changes, and I felt better afterwards. But along that diagnostic pathway, even when I got home, I then thought to myself, well, am I going to have the social support that I need to get through this period, to really do what it is that I'm supposed to do based off of this discharge paperwork? And being that we're socially isolated, social support looks different now than what it did before. So to summarize, along that pathway, one can see that I experienced different barriers prior to engaging with the healthcare system, during my engagement with the healthcare system, and even afterwards when I came home. And when we think about this from an equity and economic perspective, those are my two lenses. We know that coronavirus disproportionately impacts people who are underrepresented minorities, and we have to understand that there are social determinants of health that are contributing to this. There's already a tense relationship between this population and the healthcare system, and then when you add economic disparities, being out of work or being declared an essential worker and feeling like you have to choose your job over interacting with the healthcare system, I think that we can see how this may exacerbate negative health outcomes and really introduce negative issues when it comes to diagnosis as well.
Thank you, Mani. I think that I know we don't have a lot of time, and I'm sorry that that this is sort of more brief than I think we would like, but you've highlighted a lot of features related to patients' interactions with the healthcare system that affect individuals as well as broader groups. And I think your experience is very helpful to sort of frame our next set of discussions when we talk about how clinicians are managing and what they're doing to try and help with these various issues. So thank you very much for your time. I want to turn now to Kathy McDonald, who is going to explain how we are going to break into our shift and share sessions.
Great. Thank you, Susie and Mani. That was just a great introduction to set us all up for what will be a bunch of opportunities to engage more with different topics that are relevant to the bedside, to the level of encounter between patients and healthcare providers. So we have 5 breakout sessions, and you can see those listed on the agenda. What we're going to do is going to use what's called a shift and share format. And what this does is it gives you a chance to learn and engage quickly on 3 of the 5 topics. If you sort of stick with the structure, people can move around rooms however they want, but let me give you the main plan, which is with this format, you get a quick sense of a topic and you get to engage with the presenters on it. What's going to happen is you're going to go from breakout session to breakout session and have an opportunity to rotate 2 times so that you could see 3 sessions. Every 15 minutes, the session presenting hosts will pause to allow attendees, meaning all of you, a chance to shift to another breakout before the session starts up again with another round of sharing on that topic. There may be a little bit of morphing from one 15 minutes to another in terms of how the presenting hosts frame their topic. There might be some repeating if you happen to stay in a session, but you can stay in a session, you can keep moving, but every 15 minutes you'll get this chance to move. And that chance will be sort of based on a virtual bell that the presenters will speak up about at 12:30 and at 12:45 Eastern time. So on the half hour and the quarter till, when you can shift to another room. Now I know there are various interface challenges here in terms of people being on phones and on desktops, but we've put together, and I hope it's showing, a little introduction to how to do shifting between rooms in the breakout. Right now you're in the main room, and you'll come back to the main room at the end of the breakouts, but during this next 45 minutes, as you get to move from one breakout to another, let me just show you a little bit about how this should work. First of all, to access the breakout session, go to your agenda bar. And then you tap on the breakout session that you want to attend. And that's where all 5 are listed, and you'll have a chance to go to 3. Then when you're in that next screen, tap on the live stream. And following that, you'll be in the breakout room you've selected. You can enable the audio. You think you can share your camera, and you can enable your microphone. If you enable your microphone, be a little careful, of course, to make sure that it's quiet in your environment, and you can see participants and all. So when you're done with the session, then you go back to the agenda again and start the process over. So right now it's 13 minutes past, and
Kathy, I'll just add one quick thing, just for those who are using the desktop Whova app. It's the same sequence of buttons. The screens look a little bit different, but it's the same sequence of events you would go through. And for those who've been having some access problems, it sometimes helps to try another device. We've had some folks who can access from their iPad, but not their computer, or vice versa. So do give it a try. We're still hopefully ironing out some of the tech problems as we go. And send us a chat if you're still having trouble getting into the breakout rooms.
Yeah, and for right now, this will just keep sort of looping the instructions. So if you're in the room and trying to figure it out, you can come back and look at the instructions. We look forward to seeing you in the breakout rooms, and then afterwards, coming back to the main session.
Okay. All right. Fantastic. I think we're ready to go. It's been an interesting session so far. We had a great series of breakout meetings, and now we're here for a panel on the public health perspective on diagnostic testing. And I'm really pleased to introduce two panelists. We may have a third dropping in midway, Mark McClellan, but we'll jump in right now. And so it's my pleasure to introduce Ashish Jha, who is the director of the Harvard Global Health Institute and a professor at the Harvard School of Public Health and the incoming dean of public health at Brown University, and Lucy Wilson, who is a professor at the University of Maryland, Baltimore County in emergency services and formerly served as the chief for emergency and emerging infections at the Maryland Department of Health. And I'm Josh Sharfstein, the Vice Dean of Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health. So we're going to jump right in. And first question is for Ashish, Dr. Jha. How many tests do we need to control this disease? From a public health perspective, you know, not what does this one patient need, but how many tests do you think we need?
Yeah, Josh, so thanks so much for having me on. And to answer the question of how many tests we need, the first thing we really want to think about is what are we trying to use the tests for? And as you might imagine, there are just a whole series of estimates out there of what you want to try to achieve with testing and how many tests you need to achieve that goal. So we put out a number about 2 weeks ago where we said that in order to begin to open up our economy again, we should be doing at least 500,000 tests a day. So let me just kind of walk through the logic of how we get there. So in order to open up the economy, you want to be able to identify and isolate a vast majority of people who are infected. Now, you can't do everybody. In order to do everybody, you got to be testing everybody every day, which is not possible. And so we began with a strategy that said, if we begin with people with even mild symptoms, and then we contact trace everybody who is positive and test all the people that they've been in contact with, we'll pick up hopefully a whole bunch of asymptomatic people that way. And using that strategy, we think we have a pretty good chance of capturing most people who are infected, symptomatic and asymptomatic. And then if you just run the numbers based on what we think the size of the outbreak is going to be for the country in early May, we come up with about, let's say, between 500,000 and 700,000 tests a day.
And that compares to where we are now, which is what?
Yeah, so we're at about 200,000 tests a day, and that actually is an improvement. We've been stuck at about 150,000 for almost a month. But just in the last 4 or 5 days, we've seen an uptick up to about 200,000. So still far from where we need to be.
So I know that you would agree with this. It's both the number of tests and making sure that the tests are used for those purposes and for the right things. So I want to turn to Lucy. Dr. Wilson, tell me what your top priorities for tests. If Ashish can wave his magic wand and get 500,000 tests, 700,000 tests a day, where do you want to see them used and for what purpose?
So, I mean, as we were already discussing, there are so many different reasons to have tests. The tests are for diagnostic purposes, so guiding therapy and for infection control. Also, potentially, and at least in the future, to determine immunity and vaccine eligibility. But for public health, especially for disease activity. So looking at the shape of the epidemic and where services are needed. So in terms of a public health wish list, I think it would be obviously passive surveillance where you're monitoring tests through reportable lab diagnostics to public health. So you can just measure the quantity of tests, and that tells you how many tests are available and how many people are positive. And most states have required having both positive and negative test results. So you have a numerator and a denominator when you're looking at your disease activity. But then really thinking about sort of what in terms of active surveillance, because that's passive surveillance. So thinking more about active surveillance, what do you need in public health? You want to have this sentinel surveillance or targeted surveillance. And so you want to really use testing in certain populations as a proxy for overall activity. So with a lack of enough testing to test everybody, at least currently, you can do a lot of sentinel surveillance, and I can go into that more if you'd like me to expand on that.
Maybe an example or two.
Okay. So, I mean, so for targeted sentinel surveillance, you can look at different age groups. You can look at vulnerable populations. So you might specifically be looking at testing in nursing homes and assisted living, or looking in vulnerable populations like in corrections or in homeless population, looking in geographic locations, looking at people with certain comorbidity, looking at work. So are you looking at if our business is going to use testing to determine whether their efforts are effective, or looking at healthcare workers, that kind of thing.
So let's take a step back. Let's say we've got clearly the care of very sick patients. That's a high priority. Clearly, very high risk settings like nursing homes and jails and prisons and shelters. You're going to want a lot of testing to respond to outbreaks and be able to intervene as part of outbreak response. And as she said, you want people with symptoms to be identified and their contacts as quickly as possible to be able to shut down the infection. All those are public health purposes. Anything else you would put on the high priority list? I can go to either one of you there.
Did you mention healthcare workers? Sorry.
Healthcare workers, that's a good, that would be number 4. Healthcare and maybe other essential workers. What kind of testing would you like to see for healthcare and other essential workers? Maybe Lucy, I'll go to you first on that.
Sure. So I think it's most obvious that frontline healthcare workers and hospital healthcare workers could use more testing to determine whether they are themselves infected, whether they're at risk of infecting other patients, and whether they're at risk of infecting their families in the community. So certainly there. But then we understand there's sort of a dearth of testing among what we're calling essential workers. So sort of public-facing frontline workers, food delivery, groceries, transportation, those kinds of things. So doing some testing in that area.
And we say testing, we're beyond testing for symptoms. So obviously any of those people start coughing, have a fever, got to get them tested just like everyone else. What other testing are you talking about for those particular public-facing occupations? You know, what, and obviously, Ashish, feel free to jump in there too. Like when you say we want testing for them, what kind of testing are you thinking?
Well, I think we're testing for the virus. I mean, I think one of the issues is, we can talk about immunologic testing and antibodies and whether it confers immunity, and that's a super important issue.
Right.
We'll
get there.
Yeah, I was going to say we're going to largely get that separate. I think you're looking for active disease, because what you're trying to figure out is, are they going to spread it to other people? And so.
So do you think healthcare workers should be routinely screened, even if asymptomatic? In other words, when we're talking about testing these populations of essential workers, are we thinking about testing beyond just for symptoms, for example?
So, I mean, as has been discussed, asymptomatic infection is a concern and is very common. And if you look even early in Seattle in the first nursing home outbreak, the CT times, so the cycling thresholds were the same for the asymptomatic patients as the symptomatic patients who were positive for COVID-19. So I think we believe that people who are asymptomatic are highly infectious, just like people who are symptomatic are infectious. So testing people who are both symptomatic and asymptomatic is very important for disease control.
Certainly in the setting of an outbreak, but go ahead, Ashish.
No, I was just going to say, and of course, the big challenge is, how do you identify people who are asymptomatic, and how often do you need to be doing it? And for healthcare workers, I think we just have to come up with a strategy. And I mean, maybe people have developed good strategies on this. I haven't seen one, but you could imagine that people who are on who are on certain types of front lines, like emergency room doctors, ICU doctors, nurses who work in those settings, respiratory therapists, they probably need to be screened on a much more regular basis, just because their exposure levels are high. If you're a radiologist working and you don't have much patient contact, again, love radiologists, right, but probably not screening it with the same level of frequency. So really trying to do it based on, and that actually pushes you also into like healthcare workers who work in nursing homes, for instance. Those people need to be screened like all the time, in my mind, because you just can't tolerate a lot of asymptomatic disease in that population. So we just have to be
So
pretty
we
aggressive
could,
and variable. Sorry, go
right.
ahead.
I mean, I think part of the issue is without so many, sufficient tests for some of the other groups, we really haven't thought so much about what to do in these settings. And so as we're thinking about public health uses of diagnostic tests down the road, really defining the, when would you do asymptomatic testing of people, it becomes a very big question. And healthcare workers, you could imagine being at the front of the line, but you still need to come up with what the right kind of protocol is. Lucy, were you going to add anything to that?
Yeah, two things. I think that some businesses are getting the message that maybe they do need to do testing in their work site of their workers, and are looking for that kind of guidance. And secondly, I'm no expert on this, so I'm sort of asking it back to you all. The question of testing healthcare workers, for example, every 3 days, so that if you're testing them, you're kind of getting into the cycle of exposure and then onset of symptoms and viral detection. So is that a reasonable time period? Is it reasonable to do a nasopharyngeal swab on somebody every 3 days?
Right.
You had any thoughts on that?
Yeah, well, I think this is a good discussion, because I think David, whose smiling face is right there in the middle of my screen, is hoping that we will, push the envelope a little bit in terms of thinking about the public health uses. There he is. Okay, good. Thumbs up from David. So that will be an issue. I do want to start talking about things that are a little bit off the public health list. So those are our public health cases, realizing that some details need to be worked out. But to go to what Lucy was talking about, what about other kinds of settings? You framed it as some people are getting the message that they need to. I might ask the question a little bit differently. There's some people who want to. And the question is, what are they going to get for it? Is it a good idea? Could it divert tests from other things? If you start thinking about the amount of testing some people have talked about doing, you could take Ashish's 700,000 tests and you wouldn't have it one test for a sick person. You'd just be using it for everybody who shows up at a Major League Baseball game or something like that. So how do we think about, what is the public health value of testing, in these different settings? And we could take a range of them, from all the way from maybe a case where we would say, well, this kind of does make sense, like elective surgery, maybe testing, or people are going to get procedures in and around their face where there could be aerosols, that kind of testing, dentists, all the way to just, I've got a business, I'd like to test everybody every, 3 days for my business, even though it's not high risk at all. And maybe somewhere in there are universities where there are people living in dormitories. So what's the public health framework on that kind, all those different requests that probably we're all getting for, requests for consultation on? How do we think about the utility there? And maybe Ashish, I'll start with you. Do you think that competes against the supply? I know you've been thinking a lot about the supply of testing. And so, is this just a rounding error on the testing for public health? Or do you think that there's a real issue that we've got to make sure that we're first controlling the community spread through public health testing before we really, turn the spigots on for everyone testing just because they would like to?
Right. So it's a great question. I don't think first of all, it's not a rounding error. It's going to end up being quite substantial. And there's a broader question, which is whether the public health community, whether it's departments of health or public health experts, are going to be able to do anything about how testing flows moving forward. And let me explain what I mean. So now there's a whole set of companies that are popping up whose primary job is to tell businesses, we will test your employees every 3 days or every 5 days or whatever, so you can bring all your employees back in safely. And so when I've talked to a couple of these consulting firms and said, hey, where are you getting your tests? And they're like, oh, we're developing a whole new supply chain. We're going straight to the reagent companies. We're going straight to the lab companies, and we're buying up a whole bunch of future tests. And we have promised them, X number of dollars. And so to the extent that that expands the playing field, I'm fine with that, right? More people getting tested, the better. But I worried a lot that I don't think this is expanding the field, that what it is doing is blocking up a whole bunch of supply chains that then when public health people want to try to expand to testing in nursing homes, they're going to find that it's going to be difficult because the companies have already signed a contract with this consulting firm to do 100,000 tests a day for businesses. So that's going to be a challenge, and it's going to be a policy issue for us that we're going to have to deal with.
And part of the issue, and I think, but I'll see whether you guys agree, is that one of the most important things, because we know testing isn't perfect from the lectures we've had earlier today, they're false negatives, that one of the things that is going to protect, what is probably going to protect any of these sites better than anything else, is a lower level of community transmission. So it's very hard to design a testing strategy for a business in a sea of coronavirus. But if there's just a puddle of coronavirus, it's much easier, for things to be safe. But it's the way you get from a sea of coronavirus to a puddle of coronavirus is through public health testing, contact tracing, quarantine, isolation. Those sorts of things are what really makes it better for everyone. So I'm curious whether you would agree with that premise, Lucy, and if that's the case, how you weigh this issue of private sector testing versus public health directed testing.
I mean, those are really good thoughts. I think that there likely will be competition, as Ashish spoke of, unless they really are using a different technology of some sort. So I agree that there could well be this competition for resources. Also concerned that sort of these point of care or rapid tests that are done at home or in the work setting are going to completely bypass the public health system. So those won't be reported. So it'll be a loss of information for public health. Maybe that's okay if we're bringing the ocean down to a puddle, by any means we can. But I think that for these external to public health and healthcare uses of the testing, we really have to think about it as part of a whole package. So the whole package is this infection control package. So you're screening your employees for symptoms. You have a contact in place. You have good sick policies. You have hand hygiene, and you have physical distancing in the workplace and all those administrative controls in place. So it's not the one thing that's going to bring the ocean down to the puddle. It's just one part of it. And if you can use it as an indicator in some way, which I'm not certain what that way would be yet, if you're not doing all out every day or every 3-day testing, then maybe it could be a piece of the puzzle.
Right. Okay. Well, that's a very important point, that if businesses think it's all about testing and not all the other things they need to do, we're definitely going to have more troubles. Just some questions are popping up. We have over 100 people listening in and getting some questions. So I'll turn to those from time to time. One just quick question on the supply chain, which is probably for Ashish, as you've been thinking about this, do you think that the supply chain is there to get us to 700,000 tests? And how about, to millions? What's the realistic, or do we have to start thinking about other testing technologies to get that high?
Yeah, so I think to get to 500,000-600,000, we probably do have the supply chain. And I see it as a bridge to the, people like Paul Romer, Danielle Allen, and actually Rockefeller last week, have all been saying, different numbers, but tens of millions a day. That requires a totally different testing strategy. Like, we're not doing that with RT-PCR. I wouldn't even know how to do it with RT-PCR. That requires just a very different approach. And we can talk about what those approaches might be, but I think, so that's fine. What I've seen is this sort of 500,000 to 700,000 is a bridge to being able to do tens of millions. And the question is, do we have the supply chain? I think for the short to medium term, we do. It's not all there. It's not like it's all produced and we just need to get it. We do need to ramp up production on some things. It's helpful as we get away from using the long nasopharyngeal swabs to shorter swabs, or if we can get away from swabs and go to saliva altogether, and competing data on how good saliva is versus the stuff you get from a nasopharyngeal swab. So if we can continue to plug away at those things, I think we can get to 500,000 to 700,000. That's probably about the max on the current technology before we really run out of reagents, before we really run out of a lot of things that are not built.
I mean, what I hear you saying is we are hoping to double or triple our current capacity, make sure those tests are used for the most important public health cases to drive down the community level of transmission, which is really going to be the most important thing.
Yep.
There are some reports, some interests, clearly employers who have vast ambitions for testing. In some cases, they may not understand the limitations of testing. In some cases, it might actually reduce their risk some, or reduce the risk to people. And, it's going to be important for innovation and expansion of testing options to be able to really to accommodate that. But also, it's going to be important to have some thought brought to that process, so that we're not just spending enormous amounts of money on testing and not implementing other things that might actually be more impactful. I wanted to go a little bit, one other aspect of testing, which is we are now in a process of reopening in this country. And our previous discussion we had in my little breakout session, we had a very interesting discussion about why is the US reopening so soon compared to some other countries, and that is certainly an interesting question. But here we are doing that. How are we going to use testing to figure out whether we're getting into trouble? We clearly are closer to the line of trouble than other countries when they are reopening, other places when they're reopening. So we will have to be quicker to see the problem. I mean, obviously tell me if you disagree with this, but how do you think we can use testing to dial up or dial down our social distancing? How do you see that happening? Maybe I'll go to you, Ashish, first.
Well, let me start off with a gentle disagreement on part of the premise. So there are other countries that are opening without a great plan, and probably a little too early for my taste, but taste is not the right word for my, from a judgment point of view.
Right.
Like Italy is going to open up on May 4th, and they're putting in a bunch of policies. But I look at their opening plan, and I think it's probably a little too early, and they're probably not quite doing it.
Okay.
Not quite. So some other countries are being a bit more aggressive.
Fair enough.
The other point I would say about the U.S. is there are some places in the U.S. where I think it's totally reasonable to open like now or very, very soon. Montana, Wyoming, and Alaska as 3 states. They have very, very few cases and a decent amount of testing. I wish they had a little more. I wish they had a contact tracing program that was a bit more aggressive. So all of that is a way of saying just a bit more nuanced, but largely I don't disagree with your basic premise. So if we get back to your basic premise of assuming that in a lot of places, Georgia, there isn't a lot of margin for error, how do we make sure that we use testing so that if disease flares up, we can catch it early? And this is the key part, right? So you've got to maximize the value of the testing capacity you do have. You've got to be looking at, and so all the stuff we've talked about, nursing homes, healthcare settings, but those aren't going to like tell you that the disease is getting out of control. By the time it shows up in healthcare, it's often very, very late. And so you do need some sort of almost a sentinel kind of tracking testing program. And if you have limited testing, that means you're going to take it away from some other place. So I don't have a great answer beyond our traditional methods aren't just going to get us there. I'd be curious what Lucy.
Great. Well, your points are friendly amendments to my question. I totally agree with you. So Lucy, what do you think in terms? What would you look at if you were, or as you are, as I know, advising people, and they're asking you, is this good? Is this bad? You've got your testing kind of dashboard. What are you looking at to make decisions for the economy?
So it's a complicated question for sure. I guess I'm still thinking about controlling coronavirus with sort of the mitigation and the containment phases. So we started with containment, we're in mitigation, we're trying to get back to containment again. And so I think that testing may be more useful when you're in the containment phase because you are really honing in on more sporadic or issues that you can tackle. So that using tests may really be different in different states. Like Montana, testing may be critical in Montana because they're in a containment phase, whereas testing may be less useful in a place where there's much more widespread disease. And so you're kind of combining it with your other proxies of illness like hospitalizations, outbreaks in vulnerable settings. You're looking at your death rates, you're looking at your percent positives, maybe even be looking at, discharge diagnostic codes, maybe looking at use of EMS and all those things. So you're putting it into that package, but it's not everything. Whereas if you're in that containment phase where you're doing your testing and your contact tracing and your quarantine and isolation, testing is so important in that setting.
So from a state's point of view, for example, there's the number of positives they might look at. There's the percent positive, which you just mentioned, Lucy. So if you start to see that creeping up, that's a problem. What about mapping the positives? I don't know, Ashish, if you've been thinking about that a little bit. You know, how would the testing potentially influence what you would advise a governor?
Yeah, no doubt, Josh. So outbreaks are, like, if your numbers are going up, they're almost surely not just going up uniformly everywhere. There are probably pockets of outbreaks that you've got to jump on early and got to control. And the best way to do that is you have to know not just where are your positives, where are they rising, not how many positives and how much are they rising, but where are they rising? And that's really critical part of this. So mapping it to as localized of a region as you can, and every day seeing where the new cases are coming from is critical part of this. I think without that, things are going to spread much more rapidly, and you're going to have a hard time containing it. So geography is a really important part of this.
Okay. We got a good question here. What country's testing strategy do you admire the most, and why?
Well, early days, it was, I know everybody talks about this, but it was South Korea and Singapore. And it's just, I think both of them, and Taiwan to a large extent. But maybe if I had to pick one, I would say early days, it was South Korea. It was large volume. There was a huge component of tracing and isolation as a part of it. And they just ramped up very, very quickly. And that's how they got the disease under control. And in many ways, they showed, I mean, I like the Singapore strategy, but remember, Singapore is like a single city state that is, that has a loose affiliation with freedom. And it's very, very, and it's just my way of saying they're a little bit, it's a little
more restrictive society.
A little restrictive society. And so whether you could translate that to the United States, I'm not so sure. But South Korea is in many ways, it is bigger, it's more complicated. And they pulled this off. And when I look today, Germany is doing a very good job. Their percent positive rates are around 7%. Their testing per capita is the equivalent of about 500,000 tests a day for us. So lots of places have been able to do this, both in terms of volume, but also in terms of the tracing and the isolation stuff that needs to come with testing, because it's not just testing.
Can you walk through some of those other metrics that you mentioned? So testing per capita, and do you see that as a important kind of public health view on testing? And also, you talked about the percent positive as a sign of whether we're doing so much testing. Maybe just a little bit of background on those.
Yeah, so testing per capita is interesting because, of course, the thing it doesn't fully capture is the size of the outbreak, right? So if you have a very large outbreak, then you just need more tests. So sometimes people say, well, we're now doing more tests per capita than South Korea ever did. But South Korea's outbreak never got that big. So there is a bit of a relationship between, given the size of the outbreaks, testing per capita matters. The only other reason I like testing per capita is a lot of Americans, or a lot of political leaders, actually, not most people don't think this, but a lot of political leaders in the United States say 500,000 per day is a fantasy. No country could ever achieve that. And so it's just helpful to say, well, Germany on a per capita basis is achieving it. It's not a fantasy. So it's more about sort of a proof of concept. Percent positive, I do think, is a really important public health metric in the sense that what we know is when your percent positive starts getting very high, it just means you're missing a lot of cases. And the number that WHO has put out is about 10%, that if you have more than 10% of your tests coming back positive, you're probably not doing enough. Again, South Korea, the kind of gold standard, was at about 2 to 3% positive. Germany has been at around 7% positive. And until about 5 days ago, America was running at around 20% positive. It's just one more metric that we are under testing and probably just missing a lot of cases. And the way I describe it to people is, think about it as, we're just not casting our net wide enough. And so we're just missing a lot of people out there who have the disease when we're at 20%.
Great. Now, I have a question for you, Lucy, which is, we sometimes talk in public health about testing plus follow-up. How would how should somebody assess whether the tests that are being done are adequately followed up? to get the utility for public health. So let's say we're able to remember those key groups that we were talking about testing: people who are sick, healthcare workers and essential workers, the high priority populations, and people with symptoms. We could be testing them, but if there's not adequate follow-up, then we don't get the public health value. What are the core things you'd be looking at to know whether the diagnostic strategy is linked to an effective public health strategy?
So I'm not sure that contact tracing has ever been done to this scale, certainly not in this country, but you would try to look at positive tests and linkage to public health and linkage to contact with a contact tracer, whoever that person may be. And you might look at time delay from positive diagnosis to linkage with the contact tracing group. You might look at number of contacts identified, and then those contacts contacted and such, and look at actions taken. So you may try to look at sort of the various steps along that process and try to assess what % of positive tests have received a contact, and what % of positive tests are linked to each other. I haven't seen a lot of description of how that will be measured, but certainly there are public health measures for, say, gastrointestinal bacteria. That there are metrics that states use for how long from the time that there was diagnosis until there was public health action, et cetera. So some of those metrics could be used in this situation too.
Great. And it looks like we're joined by Mark McClellan. I'll bring you in just 1 second, Mark. Thank you so much for joining. So what it sounds like we're saying is there's a target number of tests, but then it's also, we want to make sure that it's used for certain things that are really high public health value to reduce the community prevalence. But it's not just that those tests are used, that each of those uses could be linked to a series of measures that really show that we're getting the public health value for the test. Mm-hmm. And that if you could imagine that kind of dashboard, then we'd be able to see where testing fits in. But more generally, we'd be able to hopefully assure ourselves that we are doing the right things and seeing the response in terms of the disease. Okay, great. Well, Mark, thanks so much for joining. Dr. McClellan is the director of the Margolis Center at Duke for Health Policy, as well as former CMS and FDA director. Really appreciate your dropping in to our Zoom here. You're Zoom bombing us here midway through the presentation. And we've been talking about that kind of high level view of testing. What does testing need to accomplish? And a little bit of the tension, a very interesting side discussion of sort of the core needs for testing to reduce the overall spread of disease, as well as the very important interests of different sectors for testing, which are starting to pop up, including healthcare, to test people who are coming in for procedures, or universities, or different businesses that may think like, well, I can get some measure of safety out of testing, and the fact that all these potential uses might be competing against each other. So I guess I'll give you a little bit of an open-ended question so you can jump in here, but what do you think the critical, public health policy questions for testing are? What do we need our testing to accomplish for us right now?
Well, first off, Josh, just a thanks to you and the conference organizers at Hopkins. I can't say enough about the impact that a number of components of Johns Hopkins have had on the response to the pandemic. And as a school, it was very well set up in terms of health security and public health programs, and Josh's programs and others to bring a lot of good ideas to bear. And it's just great to have the continuing opportunities to collaborate with you all as we work through these responses. And I would say in terms of the value of testing, it's all of the above. And especially as we move further away from these extreme distancing steps that we've had to put into place, there are going to be more and more needs. In the roadmap that Scott Gottlieb and colleagues and I outlined, we envisioned this second phase of moving out of the intense surge response and the extreme isolation measures as depending in a fundamental way, not just on testing, but the ability to respond to positive tests and move from the need for these very broad-based isolation steps to essentially a much more proactive way of identifying and then clamping down on outbreaks where they occur, and to make it feasible to even envision that. And it's never going to be perfect with a virus that's as difficult to contain as this one, and in a country as diverse as this one. But to get as close as possible, we need to have a low level of case activity, plenty of healthcare capacity to do exactly what you were saying, not just manage any surges, but deliver the kind of care that people need. And we need to support more businesses reopening and taking further steps. And as far as Masashari likes to say, testing and tracing of contacts is not a panacea, but it's definitely worth a huge investment in enabling us to do a better job of it. So, there have been a lot of reports out, ours included, that have somewhat different numbers about the amount of testing that's needed to support reopening. I think the practical reality is that reopening should happen, and I think will happen gradually. I think there's some states that are going a bit too far, too fast. Ashish and I had a chance to comment on this a bit yesterday, but we do need to make progress on reopening. And the more tests we have and the more associated capacity we have for response along with that, that'll make it easier. If the testing level that we can feasibly reach in the next couple of weeks is 2.5 million, say 3 million tests per week, let's make sure we're maximizing the value of that use. And that's not just prioritizing things like people who have symptoms and healthcare workers, and kind of the highest risk settings for testing asymptomatic individuals like nursing homes, assisted living facilities. But it also means making sure we've got distribution systems in place for so that swabs and reagents are also matched up, and that anyone who's ordering a test in these areas or any patient who's getting them knows where to go to get it quickly. There are a lot of gaps in that matching up supply and demand that's still happening now. It's just like what happened last month when we were trying to get surge capacity of hospital beds and vents, and governors, mayors, regional leaders had to figure out situational awareness and do the sort of the wartime logistics management to get all that matched up. And then there's a need for more federal support to increase the total level of testing, the reagents, and so forth, and hopefully maintain and improve the quality of the tests and their ease of use as well. So I'd like to see us start with what's most important, and start with some reasonable and safe reopening steps along the way in the coming weeks, recognizing that we don't have as many tests as we'd like to do everything, but that we can, along with other steps like getting healthcare providers more involved in building an integrated public health response system, and business care among businesses, and taking the really important steps to reopen under the new normal appropriately. But I hope we can get the most value out of the tests that we do have and make some real progress on sustainable reopening.
Well, I think that's great. I think it's going to require a little bit of a shift, which I think is starting to happen, from people seeing tests as just in the clinical setting for themselves to the value of tests to be able to control the disease, to link it to contact tracing, to link it to outbreak control. Like that's a little bit of a shift for the pure kind of clinical mindset that, we generally bring to things when we're not in the midst of a pandemic. But I think that shift is going to be pretty important. Here's maybe what I want to do is just, we've got about 10 more minutes here. So one question that just came in, and then also I want to talk a little bit about antibody tests before we're done here. I think we're assigned the proportional amount of time for antibody testing, maybe for the policy discussion, given where the science is right now, but we still want to catch it. So one question is, how does the data on the effectiveness of testing, the accuracy of testing, affect these different public health uses? So, we're aware that, different modalities might have somewhat different, numbers associated with them, but certainly there are false negatives that are known with the PCR. How does that affect the use of testing as a public health strategy for some of these different areas that we're talking about? Any thoughts on that question? Lucy, you're muted, I think.
It can limit the utility of the tests. It makes those types of tests most useful for looking at the population and doing surveillance, and it can cloud the issue in clinical settings in terms of looking at healthcare workers who are working with high-risk patients if there's inaccuracies of the test. So I think the testing has its greatest utility for public health surveillance, and then it has to be taken with caution in other settings.
So partly what you're saying is, for example, a hospital may be able to use testing to probably reduce the risk somewhat for people in the operating room, but that doesn't mean that people in the operating room can't be thinking about PPE at the same time. Is that fair?
Yes.
And similarly, there may need to be some judgment brought to contact tracing and other things if people have a negative test, but they've lost their sense of smell, they're coughing, they have fever. That may be built into public health programs to be aware of a false negative and perhaps respond as if somebody had it, even in the face of one negative test sometimes.
I say this matters a lot in the community too, not just in the operating room. We're trying to massively scale up our ability to do testing for people even with modest symptoms, or in some settings no symptoms at all out in the community. And to the closest thing we have to a gold standard for these tests, for whether you're shedding the virus, whether you're actively infected, or some of these hospital lab and other lab-based PCR tests, which are pretty sensitive, at least most of them that are well done, because they basically work by getting a bit of sample that includes the viral nucleic acids and then multiplying it lots and lots of times. That makes them really sensitive. Well, a lot of the tests kind of out there in the point of care world, when people think about some of the strep tests and other rapid tests, they are based off actual viral material. And if there's not that much of it, they may not be that sensitive. If you try to pick up more sensitivity, they may not be that specific. So this is not a panacea, and it needs to be, the test properties need to be considered as part of the overall response of continuing distancing steps, other isolation steps when you have symptoms, and so forth. And we're still working all that out. Just to have one final point on here that I think fits into the serology area too. When we didn't have any diagnostic tests available, I totally appreciate the attitude at the FDA of being kind of opening the gates. Let's get these on the markets. Let's learn about how they work. Now we're getting to the point where we're not all the way there, but we've got a larger number of tests that can be used in these especially sensitive areas for containing the outbreak. We want to make sure those are good PCR tests, have the rapid capacity to get the sample and then do them. But as we're now expanding out to additional kinds of tests, it's time maybe to tighten the standards a bit and look carefully at least creating incentives for, if this goes for serology too, if we're going to start using these for even moderately important decisions, let alone huge decisions, like is someone safe to work in a high-risk setting because they've got immunity. Even more modest decisions than that, let's try to encourage a higher level of test quality through our standards and payment incentives.
Yeah, go ahead, Lucy.
I was just going to say that as we get treatments available, especially if there's limited access to treatment, this again will become very important to have accurate diagnoses. So,
great. Let me ask if there's any other comments on serology. I think there's been some good reports written about the state of the science there. The point that Mark just mentioned about the variability of the products on the market, the certain hope that some of these tests will really come to bear a good prediction of immunity, but not yet realized as the research is ongoing. Any major other comments on the use of serology for public health right now? Certainly, it informs the estimates of the spread of the virus and our understanding of the virus. But yeah, Ashish.
So that's what I was going to say, Josh. And what I was going to say is if you kind of cut through all the kind of noise about how much spread there has already been, I think what we're finding is a pretty consistent pattern that we've been underestimating kind of the disease just through the diagnostic testing, that the actual prevalence is maybe 10 to 20 times. So the number of people who've been infected. So 10 to 20 times is a lot, but it's not 100 times. And that's an important distinction, right? Because 10 to 20 times means that maybe 3 to 6% of the American people have been infected already. But it doesn't mean that 30% of American people have been infected. Right? And so there is this sort of very strong desire by a small number of people to sort of claim, oh, we're all like halfway through herd immunity. We're almost there. We're not almost there. And there's a lot of problems with the serology testing, and that's driving some of those unusually high estimates. But I think as we get better at serology, we'll find ourselves saying, 10 to 20x is still a good number of people who've been infected that we didn't know were infected, but it's not 100x.
Yeah,
I agree with Ashish about the point on herd immunity is not going to be a useful strategy, I think, for the foreseeable future, and probably hopefully it won't be ever for the duration of this pandemic.
I hope that's not the strategy we have to use.
That's right. But there are some uses if we can improve the quality of the serology test, their reliability, their accuracy around things like just figuring out how widespread this has been in our communities, and supporting the track and trace, the test and trace efforts and the like. But we do need to get past the level of just having a lot of tests on the market and have a clear pathway for encouraging the development and adoption of tests that are accurate enough. And then let's start with getting accurate community level prevalence data, and then see about some further, stepwise applications beyond that.
That's great. Thank you. I'm going to end with this last question and pose it to all of you, which is, what would you like to see the federal government focusing on with respect to testing for the next 30 days? So sort of like the rapid fire. What would you want them to have as their first priority for the next 30 days? Ashish, I'll go to you first.
I'd like them to do two things at once. Short run, focus on solving state problems, that states are encountering different roadblocks at different levels. I'd like the federal government to be a real partner to states in ramping up testing, fixing supply problems, et cetera. And then the second is I want to see big incentives for those breakthrough technologies that are going to lead to 30 million tests a day or 10 million tests a day, some big number, because our current technology can't scale to those numbers, but there are new technologies that are possible. So I'd like to have them do both of those.
Great. Lucy?
So those are great points. So I do think distributing tests to states, making sure that they are available for diagnostics in clinical settings as well as for public health surveillance.
Great. And Mark?
So I also would add, in terms of supporting the states, the states are having to do this hard work on sorting out logistics and supply, federal support for best practices on that, how to do that right, benchmarks, and so forth, plus helping to come in areas where there are shortages, including swabs and testing materials and reagents. And also, I think some more federal help for engaging healthcare providers. The healthcare providers are still ordering the vast majority of these tests. It's who people trust. It's where they're going to go to interpret the tests and hopefully get connected to the public health tracing systems and the like. Let's get the healthcare providers much more in this effort too. Most of them are not participating right now.
Great. Okay. Great thoughts. Please join me in thanking. I'm trying to figure out how everyone can express their gratitude to you. Maybe type a little thank you if you are moved into the chat, or turn on your camera and give a wave. Although we can't see you, so that won't work. I think the chat is probably the best. They're just pouring in the thanks. They're just pouring in through the chat. So seriously, though, I really appreciate it. Ashish, Lucy, Mark, thank you so much for joining us here at the Armstrong Institute today to talk about diagnostic testing and public health. And it's back over to you, David Newman-Toker.
Well, thanks so much, Josh, and thank you to our panelists. It's amazing to have such incredible speakers here with us today for the audience's benefit and for the world's benefit. So thank you again for your participation. This has been amazing. We're coming to the end of our session, and I'm going to take a few minutes to do our closing moments here. I'll start a little bit with a bit of a wrap up. Obviously, we've heard many different perspectives here. We began today thinking a lot about diagnostic tests, and at the sort of bench level and the test development level, we've worked our way through a lot of clinical questions around improving diagnosis, not just for COVID patients, but for non-COVID patients in a time of great complexity and diagnostic uncertainty. And we just had an amazing session there led by Josh with our incredible speaker panel, Ashish, Mark, and Lucy, that provided us really a bird's eye view into how public health and public policy can help us. I wanted to just summarize some of that by thinking a little bit about how all of that ties up back together into how we would deliver some sort of ultimate national strategy, a coordinated strategy, or comprehensive strategy. And I've just got a couple of slides on that point. The first is to think a little bit about the sources of error in tests. So obviously, Yuka Manabe showed us earlier this diagram about the evolution of the viral infection. And that obviously means that at various stages of the disease, the different tests are going to have different properties. They're going to be useless early on. They're going to be more useful at some later time, then they're going to be useless again. And those kinds of problems are things that we have to face as we think about our testing strategies. Likewise, sampling error, the proper sampling technique is actually quite challenging to accomplish with the nasopharyngeal swabs. It's uncomfortable for patients. And sampling error leads to a lot of false negatives. Mishandling of samples potentially leads to false positives as well. Yuka just recently told us about a recent test where they had a host of tests that were essentially 100% incorrect that they reviewed in the Hopkins lab. And when you have imperfect tests, your consequence is that you're going to be dealing with the problem of false positives and false negatives on a regular basis. Here's just a simple table that shows the relationship between the prevalence of the disease in the population being tested and the number of false positives and negatives for a hypothetical rapid PCR type test with a sensitivity of about 70% and specificity 95%, which is roughly what we expect a lot of these molecular diagnostic tests we've been relying on heavily are about. And what you can see is that these are great tests for situations where you're going to have a relatively low level of prevalence. If you see somebody who has his chances that you're going to have a false negative are quite low. But if, for instance, you're in a hospital setting and you're in the ICU in the midst of an outbreak in New York City, there are going to be a ton of false positive tests, even with, a ton of false negative tests, even in patients who've been in the hospital and maybe they have relatively mild symptoms. So it'll be hard, for instance, within a hospital during the midst of an outbreak to rely on a negative test as evidence the patient doesn't have COVID, and it'll be almost impossible to maintain COVID clean spaces. Ultimately, what this translates to, and I hope this came across, I think it was incredible, the discussion around the public health challenge, is that what we're trying to do is construct a diagnostic strategy that leverages the right kind of tests to deliver on a public health goal. So we have at least 5 kinds of public health goals. We have a surveillance goal, we have an outbreak control goal, we have a workforce restoration goal, we have a diagnostic triage goal, whether that's for deciding on COVID illnesses or non-COVID illnesses, and we have a resource allocation in care settings such as the hospital goal. And this combination of goals means that we need a different testing strategy potentially for each of these problems and potentially distributed out at different levels of the healthcare system. So this is a critical perspective that we'd like to bring from today's conference back to you in the audience as we think about addressing this problem, not in a one-size-fits-all, let's just get more tests, sort of cry for more tests, but instead to take a thoughtful, smart strategy towards enhancing the testing capabilities in specific settings for specific public health purposes. We hope that some of that messaging has come across. At this point, I would like to come to the close of our conference by first big thank you out to all of our speakers who were incredible and generous with their time and efforts in joining us and contributing to the robustness of today's discussion. I have to give a huge shout out to our Center for Diagnostic Excellence staff, including Mehdi Fanai, who in addition to being a physician and a researcher in his own right is also a tech guru who has saved us on any number of occasions with his capabilities. Io McClenny, who helps with our strategic partnerships and helped us gather the troops for this particular event. And Mariah Rencher, who is our administrator and keeps the calendar in order, which is quite a challenge often. But I have to give my biggest thank you and virtual hugs to, as we call her, Vanessa Llewellyn, our Center for Diagnostic Excellence Program Manager. I wish I could be there in person right now to give her flowers and the hug that she so richly deserves. She has been an absolute stalwart on this. Her commitment to this summit has been unparalleled. She built an entire summit that was totally different than this one, and she had to completely start from scratch, move that summit off to next year, and then make this one happen over the course of just a couple of weeks. So huge, huge round of applause, hugs, and thank yous to V for a job incredibly well done. And in this last slide, I just want to thank all of the attendees for your participation, for your engagement, for your sticking with us through the event. And I hope that you will complete your evaluations. It would be very helpful to us as we sort of move into this new world order of virtual conferences to find out what worked and what didn't. And in particular, to let us know what kinds of tech problems you experienced along the way. We will be posting these conferences on our Johns Hopkins website as soon as possible, with the intent of making them accessible to those who had challenges in accessing the technology during or were not available at this particular time. With that, I will again thank you and close the conference. We appreciate your being here, and stay safe and go out there and do good work. Have a nice afternoon. Bye-bye.